All right, well, welcome everyone to today's webinar. I'm Elizabeth Krupinski. I am the co-director of the Southwest TeleHealth Resource Center. Next slide. I would like to extend a very special welcome to everybody who's joined our webinar today, but especially those of you from our Southwest region. Next slide. Since 2011, the Southwest TeleHealth Resource Center has partnered with the Arizona Telemedicine Program to bring you ranging on almost 200 interactive webinars. They're very informative. Today's webinar is also being sponsored by Intermountain Healthcare. And this webinar and all of our webinars are recorded and they are archived on our website. They're available on demand. And we'll give you a little bit more information about that later on. Next slide. Now, as you join the webinar today, your microphone was muted. So if you have questions throughout, and we will get to these at the end, please use the chat function in Zoom to ask those questions. They will be answered at the end of the presentation. Today's webinar is being recorded, and you'll be able to access it today, as well as any previous webinars that we've done on our website. The URL is listed on this slide, and we'll also post the URL in the chat. Give us a day or two to get this up and running. We have to process it before we get going. Next slide. So it is my distinct pleasure today to introduce you to our webinar today. TeleHealth Rehab is so much more than just video visits. And our presenter is Dr. Rhonda Taubin. She attended Tulane University for undergraduate, and then she went to Emory University for her medical degree and residency. She practiced at the Shepherd Center in Atlanta, Georgia for more than 15 years, specializing in brain injury rehab. And she began developing a rehab program when she was there, and moved to Intermountain Healthcare in May of 2020 as the Telehealth Rehabilitation Program Medical Director. With the onslaught of COVID, obviously things have ramped up exponentially, and the Intermountain Healthcare Rehabilitation Team has some really great ideas for the future. And so without further ado, let's hear about some of those ideas and what they've been doing at Intermountain. Rhonda.
All right, good morning. So I'm going to tell you about the program that we've been working on here at Intermountain. I'm going to give you an example, and I'm going to sort of pull it all together at the end. But we've got an incredible team here. It started out with mainly three of us. It was myself, as well as Stephen Hunter, who's a physical therapist and the director of internal process control here at Intermountain. And then we've got Kevin Christensen, who is an occupational therapist, who his job is internal process control technology and telehealth. So he's our technology guy. Started out with ideas mostly from the three of us getting together at the very beginning, and it's grown tremendously. We've got many people involved from the business side, from the IT side, additional therapists, and it's gotten quite exciting. So I'll start out with just telling you just a little bit about Intermountain Healthcare. It's a not-for-profit integrated health system based in Salt Lake City. We cover several states. It's a huge organization, 23 hospitals, 2,700 beds, and 185 clinics. They've also got their own insurance arm, which insures about 750,000 members, maybe even a little more at this point. We've got over 1,500 physicians and APPs, and 36,000 employees. And when we look at the rehab services alone, we've got 1,400 caregivers, including PT, OT, speech, audiology, and athletic trainers. And we cover the whole spectrum, from wellness to acute, to inpatient rehab, to home care, and to outpatient. So of course, everything changed last year. It's still changed, and hopefully some of it will stay changed, but just to talk about a little bit of the background and current state that we're in. From 2019 to 2020, telehealth increased by 70,000% at Intermountain. I found it very interesting to know that with Excel, you can't have a comma in percentages to do a graph. So they couldn't even graph this. This growth is just so tremendous. With the telehealth waivers, therapists were allowed to perform remote visits. So physicians were able to do it, but now the therapists were as well. And so that's what's really driving us to really look at, wonderful changes. I'm going to tell you a little bit about what we've got, something called ROMS, it stands for Rehab Outcomes Management System, that we use to help predict outcomes. And we've been able to show that with telehealth, the outcomes are comparable to in-person visits. So we're really hopeful that, all of this data will get to the correct people so that this will be able to be continued in the future. At this point, our patients like it, the providers like it, and the national data is showing high satisfaction. So we're really hopeful that this is just going to help us, catapult us into the next phase. So what I'm going to do is I'm going to give you, I've sort of done this all through the example of total knee replacements or total knee arthroplasty. It's just an easy way for me to demonstrate what our vision is. So this could be obviously provided, looked at in many other different scenarios, but this was just an easy way to show you. So we've had several software applications that we have are working with that will be able to add data from a telehealth perspective to be able to improve and make it easier for our documentation with a telehealth visit. So what I'm going to do is I'm going to tell you about the different applications. And then at the end, I'm going to pull it all together so that you can see exactly how it would all work. The first one that we've been looking at was something called capture proof. So with capture proof, what happens is the patient takes their phone and they're given various instructions. So their instructions might be to take a picture of their incision. They can then also do some videos where they might be instructed to sit in a chair, put a black towel over their good leg, and then take video while they're performing range of motion at the knee. And then that they're able to take that video and turn it into actual data with a graph that will show you the knee range of motion. They also have a system where you can put reflectors on the toes of the shoes, and you can look at the symmetry of the gait. So, at the beginning of their rehab, you might expect that they might have an antalgic gait. It might be painful to bear weight on the leg that just had surgery. And so probably the symmetry will be off, but hopefully as time goes by, you'd be able to see that the symmetry becomes more symmetrical, and that also is graphed. I'm going to go off just a little bit from our total knee replacement and just give you an example of another thing that has come up for us. Like as we start talking about wanting to implement these things, we always come up with these ideas. And I think that this one's a particularly good one as well. Capture proof could also do the timed up and go test. And if you're not familiar with the timed up and go test, basically what the patient does is they sit in a chair, they stand up from the chair, they walk 10 meters, they turn around, they come back to the chair, and they sit back down. And there's all kinds of studies that show that if the time it takes to do this is greater than 14 seconds, I believe, that a patient is at increased risk for falls. So we came up with this idea that if a patient comes in, say a 75-year-old person comes into the ER with a history of falls, and we're concerned that, that they're going to be, was this just a one-off incident, or is this a new problem for them? You might be able to send them a request to do this time up and go once a month, say, and just make sure that they're not developing a problem where we might want to intervene with physical therapy before they have a serious fall. So again, this is a little bit of an aside, or maybe you want to do this just for everybody over 75, just to be able to identify people at risk, before it happens. So this is a little bit of an aside. It's not part of my example, but it was just another example that we came up with of ways that we could potentially use this. The next software application that we are using is something called MedBridge. Many of the therapists might know about this, maybe not. But basically you can prescribe exercises to a patient. And the nice thing about it is they can click on it. They can watch a video if they're not sure if they're doing it properly. It's also got some tips on how to do it properly, and some education. The nice thing about MedBridge also is that it has a whole education component for therapists that they can earn CME credits as well. So this is another piece of our vision. The other thing that's nice about it is that you can document their compliance. So you can see when they log on and make sure that the people are doing their exercises. Okay, the next one is something called Notable. Notable, what it does is you send out a list of questions. The patient answers the questions, and then it can use artificial intelligence to generate a paragraph. So this one is one of the ones that's really most exciting to me. The idea of being able to minimize the amount of time that we spend documenting. I'm not sure there's anybody that would argue with me that they wouldn't mind giving that up. So what would happen is on the day of a visit, we might send out some questions, and then once they fill out those questions, that would automatically populate, say, the history of present illness. And again, I'm going to show you how this all works later, but we would then use that information from the history of present illness, combine it with the information from Capture Proof and MedBridge, and being able to formulate a note. Okay. I mentioned a few minutes ago the ROMS data. So ROMS was developed here at Intermountain. I believe that Stephen Hunter was largely, one of the people who started all of this. And basically, it's a database of over 3 million visits for over 20 years. So they are able to take data. So for example, if John Smith is a 70-year-old gentleman with a BMI of 35 who just had a total knee replacement, we have data that will show us what the expected progress should be. So you would be able to potentially have the therapist as well as the patient see a graph of their expected progress and then see their actual progress. And this could be motivation to the patient if they know that they haven't done their exercises for a couple of days. It could be information for the therapist to maybe tweak the exercises or see if there's a problem or something's going on, to see why they're not progressing as expected. We ultimately imagine also being able to pull all of this information together and be able to triage patients. So for example, if Mary Jones, it would come up in red if there was something that needed to be addressed or something we were concerned about. So if Mary Jones, if on Capture Proof, it looks like there's a possible wound infection, and the way that would come up is Capture Proof looks at the hues and the colors. So there might be something set so that if there's an increase in redness or an increase in green drainage or something like that, it could trigger a possible, that we need to take a look at it, that there might be a possible wound infection. We imagine also in this triage that if there were a possible wound infection, there might just be a hyperlink there that you could click on so that you could actually see what the wound is looking like and potentially bring them in maybe the next day instead of their regularly scheduled appointment a week from then. So potentially you catch things earlier. If John Smith, when he was filling out his questionnaire on Notable, started to report increased pain, increased narcotic usage, less walking. Again, it would trigger the team to call up John Smith and find out sort of what's going on. Did he go too far one day? Did he have a fall? You know, why is it that he is not progressing as expected and has turned, you know, the wrong direction? If Sue Brown comes up and she's below expected on the ROMS data, then again, that could prompt a phone call where you would call them earlier than maybe their next appointment to find out if there's something going on that needs to be changed. If Juan Martinez hasn't signed in to do his exercises on MedBridge in 4 days, again, it might send out a little reminder that just says, you know, we really need you to do your exercises. That's how you're going to get well. And then lastly, hopefully you'll have many more in the green that are progressing well as expected and don't need anything beyond what was, you know, already planned. So we've been working on trying to streamline this in, Icentra is our Cerner product for electronic medical records. And so we've been slowly chipping away. You know, Intermountain's been amazing about, you know, keeping this moving forward, but it's a big project. I think we're all really excited about it, except for the IT people. It's a lot of work on their part, but trying to figure out how to get this streamlined into our electronic medical record. So as far as where we are now and where we're going, as far as, you know, our hope, well, our belief is that by implementing these changes, we would improve efficiency, decrease costs, and potentially increase both billing and patient time. It's not just a convenience, it's also going to provide increased access for both patients and caregivers, whether that be for people who are living further away in rural areas, or also for somebody who just can't get away from work or doesn't have somebody to bring them in. It's a much easier way for them to get some of their visits accomplished. Our goal would be to get this fully integrated. We still have a lot of room to move. You know, and the key is going to be making this so that it's very easy for everybody to do. At this point, we use some of these software applications. Some of it is inefficient, and I'll show you that, and can be quite frustrating for both patients and providers, and it's going to have to be easy or it won't work. And in some cases, you know, sometimes the therapist will just say, it's easier for me to just do it the old way, and we don't want that. So basically where we are and the progress that we've made, as of November of 2020, we were able to get all 1,400 of our therapists onto the telehealth platform. We use a Vizio, which is through Amwell. So we were able to get them onto the platform. As of January of 2021, we have now gotten single sign-on for MedBridge, which makes it easier. And I'll show you that in a few minutes. In January of 2021, this one's a big one. We are now able to send out either an email or text with the ROMS questionnaire so that they can do that prior to their visit. And that's been a huge change for us. The things that still need to happen, we're working on, at the moment, we're getting closer to getting MedBridge integrated into our Cerner product, or Icentra. We're also working with Capture Proof to get that integrated. Notable is probably a little bit further on down the line for us. The triage dashboard, we haven't really, that's a dream, but I'm hoping we'll get there. And what we're also wanting to work on is being able to have the patient be able to access all of these with a single sign-on as well. And I'll explain that in a minute also. So basically, this is what it looks like now. And this is not where we want to be. The caregiver has to log on to MedBridge, and then based on that information and whatever exercises they pick, they then have to transfer that information into the medical record. Then the caregiver would have to log on to Capture Proof and then take the information that was obtained from capture proof and transfer it into the medical record. Then the caregiver has to log on to Notable, has to take the information from the questionnaire that was given, transfer it into Notable. I'm purposely belaboring this point. It's not efficient at all at this point. Then the caregiver has to log on to ROMS and transfer that data into the medical record. Okay. We do have it now where we have single sign-on to iCentra, to the Cerner product, and we do have the Avizia video visits embedded in there. So we've since then been able to take out a couple of steps. But basically, for the caregiver, there's 6 different applications they've got to log on and 4 different patient data that need to be manually transferred. This is highly inefficient, as you can imagine. And then we looked at it from the patient standpoint as well. The patient has to log into MedBridge. The patient has to log into Capture Proof. The patient has to log into Notable. The patient, well, not anymore. Now, we've been able to send text messages and emails for Notable, for ROMS, and for Avizia. So there have already been some changes there since we started this process. But basically for the patient, they'd have to log into 2 different applications, and then 3 different applications would be sending them email or text information, text communications. We would like this to be able to happen through the portal, which we call My Health Plus, where they'd be able to access all of this. And again, I'm pulling all this together at the end, I promise. So we actually did a recording, which I will not make you go through because it was quite painful actually, on the current inefficiencies. So we recorded exactly how long it took for each of the different things with a typical 30-minute physical therapy appointment. So it took 1 minute and 51 seconds for preparation before the telehealth visit, 2 minutes and 47 seconds for the Avizia login and patient setup, 1 minute 34 for setting up documentation. The big one was ROMS documentation. The questionnaire took 9 minutes and 10 seconds, all of these of which were not billable. Okay. Then we would get on to the visit, and you'd have direct patient care, which included the assessment of how they were doing, the exercises and patient education. That took about 8 minutes, and that was billable. Documentation that was accomplished during the visit was about 1 minute. And then MedBridge exercise setup and assignment was 4 minutes and 48 seconds. And again, that was billable. And then the documentation for MedBridge, another 2 minutes, 23 seconds, that was not billable. So basically, when you look at this, the current billable time was 12 minutes and 48 seconds. The current time that was not focused on patient care was over 22 minutes. So we took a look at this and realized that just by getting the ROMS data ahead of time, which was 9 minutes, and if we can get the documentation for MedBridge for 2 minutes and 23 seconds, that would add 11 minutes, 33 seconds. If you add that to the 12 minutes, 48 seconds that they can bill for time, you're now over 24 minutes, which is 2 units of therapy as opposed to 1 unit of therapy. So you're doubling patient facing time and less documentation time. So we know that this will make a huge difference if we can make it happen. Okay. So I'm going to go through each of the different applications just a little bit more in detail, sort of where we are. And then at the very end, I'm going to show you what we envision the note looking like and what that would mean to clinicians being able to take time with patients, spend time with their patients that we enjoy doing, and decreasing our documentation time, which I think will be wonderful as well. So with MedBridge, as I said, it's an individualized online home exercise and education program. The problem with it is the assigning of the exercises is terribly inefficient, and that's what we're working on. We've figured out that it takes at least 7 minutes per visit, And if we average 348 visits per month, we're talking about 40 hours per month of inefficiencies. So the potential revenue and increased time with the patient is significant. We have accomplished getting on a single sign-in. We're still working on getting the documentation into the medical record. And ultimately, as I said, our patient portal is called My Health Plus. The goal would be for the patient to be able to just log on to My Health Plus and be able to pull up their MedBridge exercises right there. And this was the example, the Heal slides. This is what it looks like. It's a wonderful application. The Rehab Outcomes Management System, or ROMS, as we talked about before, is a database of 3 million visits over 20 years, so that we've got some wonderful data and expectations for how patients should be progressing. It looks at patient outcomes and documentation and demographics and helps with decision making. So for example, we know that if we have a 60-year-old with a BMI of 30 who had a total knee replacement, that perhaps maybe it takes 8 physical therapy visits. And I'm making this up, but this would be probably pretty accurate. Whereas if we have an 80-year-old who has a BMI of 35, we know that they might take 13 visits. So it helps in being able to save you resources and use them as needed. The challenges, as I said, we are now able to email the collection information, the form, but that just happened. And then what we need to happen is to be able to enter that outcome data directly into our medical record. We would like for the patient to be able to access that information, again, from their My Health Plus account, to be able to pull up and see how are they doing compared to what's expected. And making that as easy as possible. So, perhaps in this diagram, the patient was, maybe not doing their exercises as prescribed, and then they saw that they were falling below the expected progress. It also makes the patient more accountable and more involved in their care, which I think is really, really great. And maybe that's what prompted them to then be above the blue line. With Capture Proof, it's remote patient entry of range of motion, gait analysis, and wound status. The nice thing about this, obviously, is that they can do this from home. So, we can also look at the data week by week. So in other words, we would be able to look at their incision and compare it to, the week before, maybe 2 weeks before. Same with their range of motion and gait analysis to look at their progress. So this is real objective data that we can use. It would decrease the number of in-person visits. Who knows? Maybe that means we need decreased office space in the future if we're able to do more of our visits this way. We were assisting with some of the application development. It's come a very long way, and I think it's pretty close to ready to be looking at the integration, which will be the next step for it. And then again, wanting to be able to have the patient be able to log into My Health Plus, pull up the Capture Proof, follow the directions for taking the pictures and the videos, so that information is all then loaded into the medical record. Notable was the one that I had mentioned for the documentation for using the artificial intelligence to bring in the information based on answers to the questions. So it automates the collection of patient information. There's less time collecting the patient data and more time interacting with the patient. So the day before, you might send out that question that asks, what their current pain level is, what their current medications are, if they've decreased their use of pain medications, what kind of activities, have they increased their activities? And that could then generate a note, okay? This would decrease documentation time, which in my opinion, it needs to be a priority for all of the things that we look at. It's a real problem that we've got with provider burnout and turnover. And I think if we could decrease documentation time, that could help a lot. So this is starting to get integrated into some of our other systems. We're waiting for it at Rehab. So we're not quite there yet. And then Avizia, as I mentioned, was our Amwell product. It's, a very easy to use platform. Basically, you just click on it. We're using it across the Intermountain platform, which is nice. So when a patient is logging in for a video visit, whether it's for their physical therapist or for their primary care physician or their oncologist, it's the same everywhere. So that's good. There's not new learning for how to get onto the video visit. It allows increased patient access, treatment options, and efficiency. And the good news is we've got all of our 1,400 therapists now on there. We're looking at trying to get a few enhancements made to it. So one of them, for example, with speech therapy, if a speech therapist maybe needed to demonstrate something, with their mouth, of how to make a sound, maybe if somebody's aphasic, we would like it so that when it's focused on the therapist, it maybe could make the screen larger for the patient so that they could see what they're supposed to do, and then be able to change the screen size so that when the patient is performing it, the therapist would be able to see if they're doing it properly. So that's one of the things we're working on. The other thing is, obviously with video visits, the equipment that is needed. You really need 2 screens, a camera, and a microphone. And it's probably not, the most efficient for everybody to have that set up. So we've talked about having, a telehealth, a few rooms that are equipped with telehealth equipment, so that if you have a telehealth visit, you'd be able to go into that room and have all the equipment that you need to be able to do it most efficiently. So I'll show you now what our ultimate vision of what we would like this to look like from both the caregiver and the patient side. Ideally, we would have a system in which the patient would log into their MyHealth Plus or their portal, and they would be able to get to the ROMS data, Capture Proof, MedBridge, Notable, and the Avizia. And then from the caregiver side, obviously, they'd be able to log into the electronic medical record and be able to get the data from ROMS, the data from Capture Proof, the exercises from MedBridge, the self-populated paragraph from Notable, and easily be able to click on one button to connect to the video visit. So in this case, the patient would have one portal to log in and no manual data to transfer. From the caregiver side, there could be a cost savings of what we figured out to be at least 22 more minutes, being able to spend time with either the patient or increased productivity. And if we can, show that the data, that the satisfaction, the engagement, and the outcomes are the same, this has tremendous potential, in our opinion. So to pull it all together, what I did here was I pulled together a note. I did it as a SOAP note. I'm a physician, so I don't know how to write a PT note, but you'll get my point. And, obviously it would just be modified. But so this is a SOAP note with a subjective, objective assessment and a plan. And I'm going to show you how this is all pulled together in the note and how this decreases documentation time for the clinician. And but not only decreasing the documentation time, but I think equally important, providing even better objective information. Normally we describe a wound, but I think seeing a wound is even better. So I think that we are not sacrificing anything with doing it this way. And in my opinion, actually enhancing it. So to me, there's no downside except for all of the hours that are required by IT. Anyway, this is how it all comes together. So if we were doing this for a total knee replacement, at the beginning, The clinician would put in whether the total knee was a right or left. They would enter the date of surgery and the surgeon's name. Okay. Then, in combination with the data I just showed you, plus the answers to the questions from Notable, it would then come up with the history of present illness that would say Kyle X test is a 70-year-old man, status post right total knee from up above on 4/3/2020 from up above by Dr. Rosenberg from up above. In the Notable, they would have listed their medical problems. So it would come up with other medical problems include type 2 diabetes, hypertension, and osteoarthritis. They would have listed their medications, which would include metformin, 500 milligrams twice a day, and amlodipine, 10 milligrams daily. They would have also put in their current level of pain. So current pain level is 4, and the number of Percocet that they're taking. They're taking 1 Percocet daily. It would pull in the information from MedBridge on their compliance. Patient has completed home exercise program 5 out of the last 7 days. Then we would get down to the physical findings. In the physical findings, we would pull up the information from Capture Proof. So we would have the wound pictures that could compare several weeks at a time. We would have the knee range of motion. Ideally, it would be in a graph form. So we could also compare that maybe also from week to week. And then we would have the gait analysis with a link to a video if you wanted to actually see their gait. It would include whatever's in their current exercise program. So whatever exercises that were prescribed the last time would be put into this note, so you know exactly what you had previously prescribed. You would also pull in the ROMS data. So we would be able to see exactly how the patient is progressing versus their expected progression and be able to compare that. And that information would then be able to give you, whether you need to talk to them about increasing their exercises more or, find out if they're having increased pain. It would also help guide your treatment as well. And then so far, if you realize, the only thing that you've had to put in are the 3 things at the very beginning, was whether it was right versus left, the date, and the surgeon. So in the assessment, it would pull it up as a right total knee replacement on 4/3/2020 by Dr. Rosenberg. Again, from the earlier information, it would pull in the problem list with the type 2 diabetes, hypertension, and osteoarthritis. And then in plan, patient's progress viewed with patient, that could be, your first line. Your second line would be, patient progressing as planned, if they're moving along as you would expect with the ROMS data or not. And so that the only thing that you would need to do, you might want to tweak a couple of sentences here or there if you needed to, but the only thing you would definitely need to do is to insert your updated MedBridge exercises and, whenever your follow-up would be. So basically, this is our vision. Again, my point was, I think that many people feel like, and the reason for the title of my project, of this talk, many people feel like telemedicine is video visits. And it's much more. It's got to be much more than just video visits. It's in this scenario, the patient, you might be able to see them every other visit or every third visit. Instead of it taking 2 hours for them to drive into the office and to park their cars and to get into the clinic and all the rest, this could be, a 45-minute visit at home. Their caregiver maybe wouldn't have to take off of their loved one maybe wouldn't have to take off of work to come bring them. There's just tremendous benefits, and I'm very hopeful that this is what the future will look like. But again, we've got to make it easy for both the clinicians and the patients, or it doesn't work because people won't use it. So that's what we're working on, and I'm certainly open to any questions after Elizabeth closes us down here.
Great. No, that was awesome. And we do have some questions. That was just absolutely great. And I love the vision for the future. And, I agree 100%. It's not just about video, and there's so much other possibilities. But I like your vision of trying to get, 5 different companies to basically communicate with each other on the system. But here, let me go through the questions. So Does Intermountain use decision support to triage a patient and determine if they should be scheduled for in-person versus telehealth for new and/or chronic conditions? For example, patient has a knee pain, should they get in-person or telehealth appointment? If they have to do a questionnaire to go through that triage process and so on.
I don't know. I think it's still fairly individualized how people schedule their appointments. I can only really comment on myself in that I don't see any new patients via video visit unless it's an extenuating circumstance that's required. But I try to see all of my new patients in person, and then we'll look at the follow-ups for telehealth.
Oh, okay.
At this point.
Yeah, no, that makes sense. How do patients get approved for PT per insurance in the first place? Does the doctor have to do a telemedicine visit? Is the doctor able to do an adequate exam to authorize PT?
So that's interesting, and that's something that's come up for me recently. So I recently moved, as you had mentioned, from Atlanta to Utah, and evidently the laws are different here. So in Atlanta, you have to see a physician first in order to have a therapy appointment. In Utah, you don't need to. In Utah, you can just schedule an appointment with a physical therapist on your own. So I think that the answer to that is it depends on where you're at. The thing that's really important that's happening right now, I mean, physicians and I believe APPs have had the ability to see patients via telehealth. I think that there's going to be much more, of patients wanting it now that they've had a taste of it. And, it should be covered the same as an in-person visit as far as insurance is covered, if it is covered. The big change is, once the emergency procedures are done with regards to COVID, then we have to see what insurance is going to do. But the point I want to make is, up until now, up until COVID, physical therapists were not able to do telehealth visits. So there is some legislation going on now to make sure to extend that. And I think that's going to be really important. I think there are many situations in which we could do a telehealth visit and not have to do it in person every time. And so I think that this should be hopefully extended and available.
Yeah, we're hoping for a lot of things to be extended and available once this is all over with respect to telemedicine. Have you utilized your ROMS data on effective treatment strategies by creating pre-designed templates of exercise by condition to further decrease time and energy spent on the exercise plan creation by your providers? If so, do providers use them and like them?
So I don't know the answer to that question, but I think that's a great idea. And I will definitely bring that back.
Kaylee, you're the one who said that. So if anybody else in the audience has done that, put it in the chat and everybody else can get that information as well. Have outcomes been audited to ensure decrease in in-person visits did not result in adverse events?
I know that we do have a research department that is looking at the results. Obviously, all of this is pretty new, but that is definitely going to be looked at and needs to be looked at. I think that we have to.
I haven't seen a whole lot in the literature on that, so it'll be interesting to see what people come up with.
Yeah, that's going to be. I think I think that we're going to need to look at both making sure that the outcomes are at least as good, at least as good, and then certainly not detrimental. But as I was talking, I mean, to me, there's wonderful potential to catch things before there's really a problem, because normally you probably have your surgery and you might have a visit in a week or in 2 weeks, but if you start getting drainage in 3 days and a reddened wound, being able to see that sooner and potentially start antibiotics sooner, hopefully it's improving your outcomes.
No, absolutely. Can you speak to your current levels and patient interest in telehealth PT as vaccination levels rise and case numbers by state decrease? Are patients still interested in telehealth? Let me stop there. It's multiple questions on this one, so I'll stop there and then we'll get to the other ones.
Yeah, so that's a great one, and something that we've been talking about. You know, obviously, they're not as many as there were originally. So we have seen it start to drop off. However, one of the things that just came up that I've started to do is, and we've talked about our therapists doing as well, is when somebody calls in to cancel an appointment, we've started offering a telehealth appointment if it's appropriate. Mm-hmm. And, you know, something comes up and now their caregiver can't bring them in, or, you know, they need to go to work or whatever it is, and they think they need to cancel, but they really want to be seen. You know, oftentimes the 30 minutes, they can find 30 minutes. They might not be able to find 2 hours. And so we have just started keeping track in my clinic and in one of the physical therapy clinics about how many people are taking us up on that offer. When we say, you know, okay, we understand that you might need to reschedule. Would you rather do it by telehealth? So far, a very large percentage are choosing the telehealth option.
Yeah,
so
like
I think
said,
that'll be a way
figure
that we
out how
can keep
convenient it is.
Mm-hmm. Yeah, I think it'll be a way that we can, you know, keep the numbers going without, you know, them dropping off too much. But yes, because of vaccinations and people feeling better, I think people just want to get out. They don't even care if it's going to the doctor or the PT.
That's a good point. How are you standardizing the introduction to telehealth to patients? And how are you setting the expectations with the provider to utilize this versus their comfort level with the in-person visits?
You know, that's definitely an issue. And certainly, you know, some people are early adopters and love the new technology, and some people, you know, are kicking and screaming, not wanting to go there. I think the real issue is going to be if we can make it easier for you, then you're going to want to do it. And so, you know, I think, you know, providing the proper training of how to do it and being able to show that it's even easier than what you're currently doing, I think will make all the difference.
Yeah, training, we agree. Training. Just even if you have to do some simulated patients before you get out there and really do it, it really does help. Can you comment on if wound image asynchronous telehealth can be utilized by either the E&M provider or PT/PTA? Thus, do you see an opportunity there for interprofessional work, but more importantly, billing payment models for asynchronous telehealth PT or rehab?
If we're asking about billing for it, I don't know the answer to that. And I think that you had said that you've got somebody for billing that might be able to answer some of those questions.
We've got we actually do. We have somebody else that can answer that, but we also have a webinar or an office hours, virtual office hours on May 19th with Carol Yarborough, who did our billing one last week. And so during those office hours, if you're interested, but we can also forward that question directly to Carol to get some answers for that. So,
but I think asynchronous visits are also a wonderful, wonderful option. And just, you know, to make sure everybody's on the same page, you know, an asynchronous visit would be, you don't have to be, both of you be on at the same time. So the patient could send that picture of their incision, their wound, and at some point during the day, you pick up that picture, take a look at it, and decide if something needs to be done for it. I don't know exactly. I would love to know the answer of how billing is going to work with asynchronous visits.
Okay.
It's a great one.
What incentives, if any, do you provide for non-compliant patients? Would something like a gift card for completing their assigned self-education and exercise regimen work? Of course, the benefits of home rehab are self-evident. Can you bribe your patients, basically?
You know, I don't know that should, I would hope that would not be necessary. It's really about their health, decreasing their pain, increasing their activity. I love the idea, though, of that ROMS data. I don't know, I guess maybe it's the competitive nature in me, but like, I would not want to be below that line. But not everybody's that way. And I understand that. But I think if you see that you are not doing what we would expect for a person of your age, sex, and build, I think, hopefully, if the next week they get closer to the line, then maybe it's just, positive feedback to say, whatever you did this week looks like it's great. You're getting where you need to be. And, we expect you'll be in great shape in 7 weeks or, something like that. Maybe you can, just give them something to look forward to.
Okay. Just a comment, would be interesting to look at therapist turnover comparison, as that has an impact on patient outcomes.
Definitely. Yeah. Turnover, and I think the turnover is important from 2 different angles. So turnover as far as, consistency for the patient, having the same therapist is, I feel, so important oftentimes, but then also for the facility, losing therapists and having to bring in new people and train, and, that's a losing endeavor as well. So, yeah. I think, most of us went into healthcare to treat patients and help people. And we all spend far too much time documenting and doing things that we really don't enjoy. And so I really am hopeful that if we could have a system similar to this that takes away that documentation, but at the same time providing at least equal, if not better, objective information, and being able to spend more time with your patients and using, your training to treat people, I think we'd have less turnover and more patient and clinician satisfaction.
No, that's all good points. How is Intermountain working to get rural doctors to provide telemedicine to their patients? Any efforts there?
Yeah, I know that we're using telehealth, they're using it critical care in the small hospitals in rural areas, where they can, connect back to the main hospital. It's really available across the board for us at Intermountain, which is wonderful because it's given, they had an example the other day of a small rural hospital that a patient had an overdose and was having status epilepticus, had seizures that wouldn't stop. And, they had, the one ER doc and the one ICU doctor, and we're struggling with how to help this patient, and being able to call into, our main facility in Salt Lake and talk to our critical care specialists and put their heads together, came out with an incredibly positive outcome. So I think it's been a win for everybody. It can take some of the pressure off some of the rural docs if they've got too many people that need to be seen. They could be seen in different locations, but it gives them backup, in difficult situations, which is wonderful. And I would imagine that'd be the same, potentially for therapists.
Yeah. Have you looked at different platforms for telehealth, like, for example, TitoCare? Or did you just kind of settle on the one that you're using and go with it?
Can you ask me that one more time?
Yeah. Have you looked at different platforms for telehealth, the technology platforms, like TitoCare?
I don't know TitoCare. I'm a small piece of Intermountain, so they make those decisions.
Okay. Yeah. There's a lot of platforms out there.
Personally.
I'm sure they looked at a variety of them before making their decision. Your vision of the future. When is the future, basically? How close do you think you are to achieving this goal in the future?
Well, so the thing that's really exciting, I started with Intermountain back in April of last year. I physically came here in May of last year. On that thermometer, let me, well, I don't have to go back there, but on that thermometer, we've shown where we've already been ticking off the items. So, I think we're going to be pretty close with MedBridge, hopefully very soon. We've already got the Avizia in there. I think we're closer to getting the capture proof piece in there. So, I'm hoping, probably a year if I had to, maybe that's,
Okay.
I don't know.
All
We'll see what
right.
the
No,
IT people say. I
that's
always think like it's no big deal. Like, can't we just do this one little thing? And then the IT people tell me it takes like 1,200 hours to get it implemented. I'm like, oh God, you know, I don't know. I think I need to go back to school to become an IT person.
probably we all do. What efforts, and this you may not know this, but what efforts are being made to allow therapists to provide telehealth services beyond state lines? So are there cross-state licensure possibilities going on there? This is particularly an issue for school therapists who would like to be able to respond to pleas for services in other states with distant learning needs and so on.
Yeah, this is all part of the, you know, the new age of telemedicine. And I think across state lines is going to be very important. You know, some states are better than others as far as, you know, they have compact licensures and things like that, where you can, it's not a huge big deal to be able to practice across that state line. And some of them are much more difficult. So there's not really, as far as I can tell at this point, there's not really standardization in that. And probably the first step is just making sure that we continue with telehealth for therapists. And then I think we need to look at telehealth in general across state lines, because it's definitely an issue.
Yeah, and two people just put a link to the PT Compact in the chat, so you can take a look at that. We got time for one final question before I do my wrap up. So how does Intermountain Healthcare see any disadvantages with telerehab? For example, do you collect any data on those who do not do well with telerehab at this point? So we can figure out, you know, what do we do in the future?
You know, I don't know that we have data yet, again, because this is all, you know, pretty new, but, you know, I certainly think there are certain pockets of the population that it won't work. You know, maybe some of the older population who is not technology oriented and has no desire to be. But I think that the beauty of this would be that the options are available, that you can go either way. You can decide, you know, there are many times that I'll say to my patients, even, you know, it's up to you if you'd rather come for your next visit, you know, in person, or whether you'd like to do it via telehealth. And I think just being able to offer that option is important.
Great. Well, thank you so much, Dr. Tobin. This has been a wonderful presentation, and we got through all the questions, I think, which is great. So this presentation has been brought to you by Intermountain Healthcare, the Arizona Telemedicine Program, and the Southwest TeleHealth Resource Center. For upcoming webinars and events, please visit our website. Next slide. As always, we super value your opinions, so please take a few minutes and complete an online survey, really very quick. As you exit, you will be taken directly to the short survey, and if not, there's the link there. So again, we thank Dr. Tobin for this wonderful and informative presentation, and all of you for attending, and we hope to see you at another one of our webinars or virtual office hours. Enjoy the rest of your day.